order. So welcome everyone to meeting number 21 of the House of Commons Standing Committee on Health. We are meeting today to study the emergency situation facing Canadians in light of the second wave of the COVID-19 pandemic. I would like to remind everyone that everyone has the right to participate in these proceedings in the official language of their choice. In the event that there is a difficulty in hearing translations, please bring it to our attention as soon as possible so that the matter can be resolved. So I'd like to now welcome the witnesses. Appearing as an individual, we have Dr. Joanne Langley, Professor of Pediatrics and Community Health and Epidemiology. And appearing with Dr. Langley is we have Mr. Roger Scott Douglas, Secretary of the COVID-19 Vaccine Task Force, who will not make a presentation but will assist Dr. Langley in answering questions. Also appearing as an individual, we have Dr. Andrew Morris, Professor of Infectious Diseases. With the Canadian Nurses Association, we have Michael Villeneuve, Chief Executive Officer, and Aidan Hamza, Policy Lead. With Doctors Without Borders, we have Dr. Jason Nickerson, Humanitarian Affairs Advisor. I would like to, before we go to the statements, I would advise everyone that I will be using cards, such as this yellow one, to indicate when there's approximately 1 minute left, and red card to indicate when your time is official or is up. And at that point, please try to wrap up. So we'll start with Dr. Langley. Dr. Langley, please go ahead. 5 minutes, please.
Thank you. Good afternoon. My name is Joanne Langley, and I'm speaking to you today from Nova Scotia. I'd like to start by acknowledging that my workplace here at Dalhousie University and the IWK Health Centre sits on the ancestral and unceded territory of the Mi'kmaq. Thank you for the invitation to the House of Commons Standing Committee on Health, and thank you, members of Parliament, for your services to the country. I'm a pediatrician specializing in infectious diseases. I'm also a vaccine researcher and clinical epidemiologist. I've been honored to work over several decades with public health colleagues on communicable disease control and vaccines to prevent and limit the spread of infectious diseases. These challenges that we've worked on together have included the 2003 SARS outbreak, various local and regional epidemics, the last pandemic in 2009 due to influenza, the current pandemic, which has affected the physical, mental, social, and economic well-being of humanity across our globe, has been unprecedented. All of us have been heartened by the speed with which science and dedicated, hardworking humans have delivered safe and highly effective COVID-19 vaccines. These advances in vaccine development are also unprecedented. But the work is not over. There are important tasks ahead for this year, and in my view, likely for a few years. We must not become accustomed to this suffering, which has affected all people, including children. Now is the time for lofty goals and for solidarity. Words and deeds matter. We must support our healthcare professionals as they take care of the sick. We must support our public health workers as they implement what is the largest vaccine rollout in our country's history. We must continue public health measures and support for them until we understand the natural history of this virus. There is much remaining basic and clinical science research to be done, and we must continue to strive to collaborate across all the man-made divisions that exist now to work together. And while we protect people within our own borders, we must continue to lift our gaze to the protection of the peoples of the world, to the low and middle income countries, and how we can serve them. I'd like to make just a few closing comments about the role of vaccines in ensuring a healthy society. Immunization has been cited as one of the top 10 public health achievements of the last century. When there isn't a pandemic, I would argue that vaccines do not always get the attention they deserve. At this time, Canadian children are protected against 16 different infections that can prevent whooping cough, death, disability, serious illness. Adults too have a schedule of vaccines that can prevent influenza, shingles, pneumonia, and other life-altering infections. Immunization is a strong but dynamic system.
Pardon me, Dr. Langley, your mic is
Yes?
just a bit too close.
Okay, is that better?
We'll try.
Okay. I use the word fragile because a robust immunization program requires public confidence, high vaccine uptake, funding, and surveillance to measure the impact of vaccine programs and ongoing research. I hope that this pandemic has sharpened our focus on the detection and prevention of infectious diseases, broadly speaking. Thank you for your attention, and I look forward to our discussion.
Thank you, Doctor. We go now to Dr. Andrew Morris. Please go ahead, sir. 6 minutes, please.
Thank you, Mr. Chair and honorable committee members. It's an honor to be able to address this committee. Before I begin, I'd like to acknowledge that I'm currently speaking what I believe to be the unceded ancestral territory of the Haudenosaunee, which is where my family home currently rests and where I'm speaking from. I'm a professor of medicine at the University of Toronto, and I'm a consultant in infectious diseases at Sinai Health and University Health Network. Prior to this pandemic, most of my academic work has really focused around antimicrobial resistance, so drug-resistant infections. And I've been doing work on behalf of the Public Health Agency of Canada, along with Jerry Wright, to develop a pan-Canadian network to tackle antimicrobial resistant infections. This is my third such appearance before the Standing Committee on Health in relation to infectious diseases in the past 4 years, so I'm really privileged to be invited again. But I will remind this committee, in fact, the only familiar face I see here is Mr. Davies. So there are many new faces, but much of the action that I've urged this committee to act on previously has not occurred. Although it was self-evident at the beginning of the pandemic when the virus was first isolated, it's worth reminding everyone that COVID-19 is just one of a host of drug-resistant infections. There are many drug-resistant infections that affect Canadians annually. We obviously estimate that we've lost around 22,000 people, sadly, to COVID-19 over the past 12 months, and many, many more have become sick. We lose about 1/4 of that figure annually due to drug-resistant infections at a cost to the Canadian healthcare system of $1.4 billion, with a reduction in GDP of about $2 billion. And we expect that those numbers are going to rise to about $7.6 billion in healthcare costs and $21 billion in GDP by 2050. We're now roughly a year into this pandemic, and it would be sufficient to say that the lives that we're going to continue to see lost around the world, but including Canada, will be due to a combination of two things. One is insufficient vaccination, primarily limited by supply, and the other one will be ineffective antimicrobial therapy. And I do want to point out, and Dr. Langley also pointed out, that as citizens of the world, both of these issues affect people throughout the globe. We need to invest in infectious diseases prevention, surveillance, diagnostics, and therapeutics. I think I'm going to attenuate what I was going to say for reasons of time, but I will point out that our surveillance systems in particular remain so poor that at present we've had to put together a hodgepodge of genomic sequencing resources to try and give us the surveillance information that countries like Denmark, that has 1/10 of Canada's population, and the UK, who has roughly double our population, can provide their own citizens. We also lack the capacity to develop antimicrobials, and we're unable to produce vaccines to serve our citizens. We have not been able to mount a coordinated response to infectious diseases, and I really want to focus for the next while on just drug therapy. I will start off pointing out that there are two evidence-based therapeutic treatments for COVID-19 that unequivocally save lives in hospitalized patients: dexamethasone, which is a cortisone-like medication, and tocilizumab, which is a monoclonal antibody that blocks a component of the immune system. Both of these agents are life-saving with comparable and additive effects. At present, we have sufficient supply of dexamethasone across the country. It's a cheap generic drug. On the other hand, we have insufficient supply of tocilizumab for the needs of Canadians. Whereas I do understand the federal government, along with the provincial governments, have been making efforts to procure sufficient supply, provinces have been sheepish to provide tocilizumab to patients whose conditions merit its use because of uncertain drug supply. And this is an unquestionably life-saving drug. The last points I want to make relate to to contrast these stories with the stories of remdesivir and bamlanivimab. And yes, if you're wondering, as an infectious disease physician, I'm used to pronouncing organism and drug names that the rest of humanity struggles to pronounce. Remdesivir is an antiviral drug whose effectiveness remains uncertain to me and many others, including the WHO. Bamlanivimab is a monoclonal antibody that targets the virus itself. It's a drug that the Canadian Agency for Drugs and Technologies in Health evaluated as neither practically implementable nor of clinical value. The federal government, through Health Canada, purchased remdesivir at a cost that is not publicly known, but what I would estimate to be $75 million. On the other hand, the government also purchased what I believe to be $32 million worth of bamlanivimab. This approximately $100 million of expenditures on effectively useless drug contrasts with the shortage of the two life-saving treatments that currently exist. What is urgently needed is a pan-Canadian committee comparable to NACI, the National Advisory Committee on Immunization, of national experts with clinical practice guideline experience and expertise relative to COVID-19 that can share knowledge and data and come up with sensible recommendations. I'm sensitive to the challenges that our federal government faces in nudging provinces and territories to row in the same direction. Clearly, this is an area where the government has not been successful. Accordingly, I and several of my colleagues from around the country who have been involved in the development of provincial guidance have decided to mobilize, mainly because of the urgency of the need and the importance of this to Canadians, and it's too great to defer these to the various levels of government any longer. In the meantime, it would be wise for this committee and the federal government to figure out how our group of national experts can either be supported immediately or catapulted to a future state where such a committee exists for all infectious diseases. Because as I said at the beginning, drug-resistant infections are not going away, and we need to approach their treatment with a pan-Canadian, evidence-based lens that brings together the expertise and interests of all people from coast to coast to coast. Thank you.
Thank you, Doctor. We now go to the Canadian Nurses Association. Mr. Villeneuve or Mr. Hamza, please go ahead. 6 minutes.
Thanks, Mr. Chair, and I apologize for disappearing. We had a technical emergency at this end, and I wasn't able to hear the first two witnesses. I apologize. I want to thank you, Mr. Chair, and members of the committee for inviting the Canadian Nurses Association to appear today. My name is Mike Villeneuve, and I'm the CEO at the Canadian Nurses Association. And I'm delighted to have my colleague, Aidan Hamza, who is our policy lead, here with me. Mr. Chair, in December 2020, Canada reached a much anticipated milestone, as you will know, as the first doses of the COVID-19 vaccine arrived and immunization programs began across the country. This gave nurses and people living in Canada the hope that the unprecedented global crisis may be brought under control. Never in history has the world of science come together at the same time to solve a common threat to humanity. And globally, scientists have deployed new techniques, shared their findings openly, worked around the clock with governments and regulators while preserving safety. 2 weeks from yesterday, we will mark the 1-year anniversary since the WHO declared COVID-19 a global pandemic. And day after day since then, healthcare workers and vulnerable populations have been suffering the most due to the pandemic. A key step in eliminating this crippling virus from our society, the Canadian Nurses Association is strongly recommending that everyone living in Canada take the vaccine as it becomes available to them. In addition, clear guidelines and a strong nursing and healthcare workforce will be critical to successfully deploying a mass COVID-19 immunization program. Nurses will be central to the delivery of COVID-19 vaccines across Canada. And in fact, it was a nurse in the UK who gave the world's first COVID-19 vaccine to a patient. As nurses, we historically have been at the forefront of immunization programs. A vast amount of vaccine delivery into the arms of human beings is carried out by nurses globally, and we've always been strong supporters of science. This was demonstrated in Canada as we saw many nurses be the first to roll up their sleeves and become vaccinated in December. As the largest group of healthcare professionals in Canada, nurses are playing a critical role not only in administering the vaccines, but in educating the public and encouraging vaccine confidence. And in carrying out their roles, nurses are ethically bound to give evidence-based, accurate, timely, and non-judgmental information to patients. CNA has been committed throughout this process and is playing a key role in promoting vaccine acceptance and supporting nurses through clear, consistent messaging and evidence-informed resources. I'll conclude, Mr. Chair, by saying that CNA continues to be extremely concerned with the critical problems that we've witnessed during the pandemic. The long-term care sector continues to suffer the most, and even with lessons learned from the first wave of the pandemic, the second wave has rehashed vulnerabilities in these homes and settings, leading to new outbreaks and many deaths of older adults. We're also extremely concerned with the mental health and burnout of nurses and all healthcare workers in Canada. The worsening mental health of nurses could lead to long-term effects for those nurses as individuals, but also for the healthcare system, including amplifying nursing shortages, which seem to be a concern in some parts of Canada. Last year, we asked nurses and found that their mental health had deteriorated significantly throughout the year, with over half stating that their mental health was only fair or worse than fair. Urgent action from all of us, certainly from governments, is needed to address these challenges. Federal, provincial, and territorial governments need to remain vigilant and continue to hear the expert voices of nurses and other healthcare professionals. Thank you, Mr. Chair. And Aidan and I will do our best to answer any questions. Thank you.
Thank you. We go now to Doctors Without Borders. Dr. Nickerson, please go ahead. 6 minutes.
Good afternoon, and thank you to the committee for having me back today. It's been said many times that this is a global pandemic that requires global solidarity and global actions. In addition to protecting Canadians, it is essential that our government unite behind a truly global response. Doctors Without Borders, or Médecins Sans Frontières, MSF, teams have witnessed a severe second wave of the COVID pandemic in many of the places where we work. In places like Mozambique, Malawi, and Zimbabwe, health systems have struggled to cope with the sudden onslaught of patients. Several African countries have recorded more COVID-19 cases in the month of January 2021 than in all of 2020 combined. And in many countries, the indirect impacts of the pandemic, in particular the disruption of essential health services, have been even more deadly than COVID itself. My key message today is that our immediate global priority needs to be ensuring that healthcare workers and other people most at risk in low and middle income countries have equitable access to the most effective and contextually appropriate COVID-19 vaccines urgently. Unless we scale up access to vaccines in all places, the world risks generating new pandemics of vaccine-resistant COVID-19 variants. If we fail at equitable distribution of COVID-19 vaccines, we fail at global public health. It's that simple. This would be morally catastrophic and a significant risk to the public health of all people, including Canadians. There are billions of people in the world who are almost exclusively dependent on the COVAX facility as the source of their vaccines. Yet it wasn't until Wednesday of this week that the first doses from COVAX arrived in the first recipient country. That's because COVAX itself is struggling to access doses in a timely way, in large part because the existing supply has so far been monopolized by high-income countries. I want to emphasize that the only reason for COVAX's existence in the first place is because the way that the world currently develops, manufactures, and delivers new medicines and vaccines is broken. It is set up to maximize profits. The pharmaceutical industry is not set up to rapidly respond to emerging pathogens with pandemic potential. It is not designed to scale up manufacturing of new health technologies to meet global demand. And as we are seeing today, and have seen for decades, it is not set up to ensure equitable access to new medicines and vaccines, particularly for people in economically poor countries. We need to change the way the world develops medicines and vaccines to prioritize developing the tools needed to respond to public health threats and making them readily available and accessible. There are vast areas of medicine that cannot and simply do not respond to the market. They're market failures. COVID-19 clearly falls into that category. A year and a half ago, there was no commercial interest in coronavirus vaccines. The same is true of Ebola and drug-resistant infections. As Canada moves toward a conversation of biomanufacturing of medicines and vaccines, it's essential that this not just be a conversation about how to incentivize private companies to build factories here. It needs to be a conversation that transforms our relationship with the way that medicines and vaccines are discovered, developed, manufactured, and delivered. This committee actually studied this issue during its study on federally funded health research in 2018. None of the recommendations made by the committee in that report have been implemented, though they could have helped avert parts of this crisis by demanding fair pricing, greater transparency and sharing of technologies, and global access to drugs and vaccines developed with Canadian public funding. It is common sense that when the federal government invests in vaccine or drug development, that it would ensure that the final product is available at a fair price around the world, including in Canada, but that's not what happens. We know that Canadians are concerned by this because more than 90,000 people signed MSF's petition calling on the federal government to attach conditions to federal funding to ensure that the medicines and vaccines that we pay to develop are affordable and accessible to people who need them. We have 3 recommendations today for this committee. 1, Canada needs a timeline for making a percentage of its doses of COVID-19 vaccines available for use in low and middle income countries to vaccinate healthcare workers and other high-risk people. Canada has publicly released timelines for when we anticipate having a surplus of doses, so Canada should release a timeline for the sharing of vaccines. This committee should ask for it. Number 2, push for the implementation of the recommendations in the 2018 study on federally funded health research and open science, which recommended that Canada make the funding that is provided to develop new medicines and vaccines conditional on recipients ensuring that they would be available to people around the world at affordable, fair prices. Number 3, request that the Parliamentary Budget Officer review any drugs and vaccines that have been discovered and developed with Canadian public funding to understand whether under a different model of production, we might have more affordable and accessible options for things like the RVSV-ZBOV Ebola vaccine that was first developed with Canadian public funding, and that today costs $98.60 per dose, unquestionably the most expensive vaccine in use in global health. As always, I'm happy to discuss any of this in greater detail, and thank you again for having me back.
Thank you, Doctor. Nous commençons maintenant avec.
We'll begin with a round of questions and answers, and we will start with Mr. Paulus. Mr. Paulus, please go ahead. 6 minutes, please. Thank you very much, Mr. Chairman, and thanks to our witnesses for being here today. My first question is for Ms. Langley. As far as vaccinations are concerned, currently there are major delays. The management of contracts is disastrous, and we need more information. Our committee needs more information, and you are part of the vaccine task force. So here's what I'd like to know from you. Do you agree that the minutes of the meetings should be published on government website such that the committee can get their hands on a copy?
Thank you, Mr. Chair, for the question about the minutes of the COVID-19 vaccine task force. The limits to date on the minutes of the task force are related to the confidential business information that the task force considers. We've tried to overcome this by making a number, media interviews, offers to meet with the leaders of the political parties, multiple seminars, and sharing information as soon as possible, which doesn't contain this confidential business information. We have all signed CDAs with the companies that presented to us.
Merci.
Well, thank you, but if I could cut you off. We understand that, but there is some way we can get our hands on the minutes, right? Everyone's trying to understand what's occurring. If you go back to the beginning of the crisis in 2020, CanSino, the government of Canada, signed off with them, and you're at Dalhousie University, and you already have a relationship with CanSino, so we're trying to understand what happened at that point. And did you recommend that the government of Canada deal with CanSino?
With regard to that particular vaccine, there are two separate processes. So the first was a research agreement with Dalhousie University and CanSino that was a result of the scientific collaboration between CanSino and the NRC. That happened before the task force. Secondly, CanSino, along with all the other international vaccines, was considered as a potential candidate. Roger, would you have anything to add to that in terms of detail?
No, I think that puts it very well, Joanne, drawing a pretty clear distinction between the work that the Canadian Centre for Vaccinology had early in May with CanSino and then the subsequent work.
Merci, Monsieur Scott.
Thank you very much, sir. Could you please explain, Ms. Langley, how it is that Canadian intellectual property was transferred to the Chinese at CanSino, and then all of a sudden they put a kibosh on the deal? Do you know why that occurred?
I think the assumption there is not quite correct. I don't believe, and Roger can explain, that there was not actually intellectual property transferred.
That's right, Joanne. The IP was owned by CanSino. It was not NRC and IP that was involved in the vaccine. CanSino did have access to the HEK 273 cell line that is very advanced and used by very many vaccine companies in the development of their products. But all of the IP related to this particular vaccine was actually CanSino. It's not the NRC's, and no money was paid to CanSino.
Okay, merci.
Thank you. Next question. We know that there are about 3 million Canadians that will be vaccinated by late March, but at the same time, we have 130 million Americans that will have been vaccinated by that time. So from what we're seeing from Pfizer's communications is that the Americans are being very quick with their vaccine rollout and that there'll be a Pfizer surplus. Is that why we'll get more vaccines in April, May, because there'll be that overflow coming from the US? Is that the case?
I think your question is whether the relationship between the company and the US is affecting Canada. I believe they're independent contracts, and I'm not sure that they're procured from the same factories, but Roger, can you fill in the details there?
The Pfizer doses received by Canada, which are being referred to here, come from European manufacturing centers, not the US.
Well, I know that they come from Belgium, but what I want to know is that there are 130 million Americans that will be vaccinated and there'll be a surplus in the US because they calculate there'll be 200 million doses. So will Canada get doses from the US instead of just getting doses from Belgium? Is that what is planned, that there will be the excess from America that will come to us?
I know that every effort's being made by government ministers to get safe and effective vaccines such as the Pfizer vaccine, Moderna, and now AstraZeneca as quickly as possible to Canadians. And they're looking at all destinations where that is possible. The current arrangements for Pfizer, though, are from the Belgian plant that you referred to.
I think my time's run out, Mr. Chairman. You have 30 seconds, Mr. Paulus. Ms. Langley, if you had an opportunity to think things over, how would you better manage the vaccination rollout?
So the vaccine task force, Mr. Chair, is not responsible for rollout, but just as an individual, I think that it's a huge endeavor that we don't have regular practice with. And I think we will learn from this in terms of pandemic planning and learning how to better deliver mass vaccination rollout programs in the future.
Merci, Monsieur Paulus.
Thank you, Mr. Paulus.
To Dr. Pawlowski. Dr. Pawlowski, please go ahead. 6 minutes.
Sorry. I think the big news for all Canadians today on the vaccine front is AstraZeneca and the fact that it was approved. We have 20 million doses apparently ordered. Looking at the numbers, I'm not sure what to think of it. And I would note that I think Health Canada has pointed out that some places have not allowed use in over 65, and Health Canada regulators have said that the results are too limited to allow an estimated efficiency in those over 65. So it seems to be a note of caution about its use over 65. Now, its efficacy seems to be a matter of question. The initial trials, I think, showed, 62% generally, but when you used half the first dose, it was up to 90%. I see Health Canada is suggesting right now 62%, WHO 63% after 8 to 12 weeks. However, there have been a number of studies reporting that after 8 to 12 weeks with one dose, efficacy is 76 to 82%. So this is perhaps somewhat confusing. Now, but I think, and here's the biggest number in the most interesting study, which doesn't seem to be that well reported, but I think maybe the most significant evidence apparently coming out of Scotland, where they have over 1 million people vaccinated, over 400,000 people having received AstraZeneca. They're reporting 94% reduction in hospitalization of those having had AstraZeneca, surprisingly lower with those who had Pfizer. And moreover, those numbers with AstraZeneca preventing hospitalization are in those over 80 years old primarily. So I'm Dr. Langley, I'm not sure. Dr. Morris, maybe we can start with Dr. Langley, and the person, is it Mr. Scott Douglas or Dr. Scott Douglas from the task force on Pfizer or on AstraZeneca, and specifically its use in the elderly, and where is this going to slot in if we're not going to use it in the elderly? Thanks.
I can start, I guess, Mr. Chair, and thank you very much for the question and for this wonderful summary of the evidence so far. Thank you. I think your summary has highlighted a couple of points. I'll just deal with them briefly. One is that each trial has a slightly different efficacy outcome. So when you compare a trial that the outcome is a positive PCR test plus one symptom to a trial like the AstraZeneca where the outcome is severe illness or some kind of, really significantly important clinical illness, you can't, they're apples and oranges. And so across these trials, we have to be very cognizant of what we're comparing. Also, none of them have been compared head to head. The second thing is that what we're seeing now is evidence from the fourth phase of clinical research, which is post-market authorization, which is a very important part of learning about vaccines, where we see what the efficacy and effectiveness is in true rollout programs. So we have to continue observing that. I think we have complete confidence in Health Canada's review of the file and that it is a safe and effective vaccine and an important part of the armamentarium to bring this pandemic wrestled to the ground.
Does anyone else want to, Dr. Morris, do you want to comment on AstraZeneca and or the use in over 65?
Yeah, and really not much more to add from what Dr. Langley said. The real challenge is that most of our research experience are in younger adults and age 65, but the growing real world experience is that it is effective, but it's going to be a matter of time in the post-marketing data for us to collect and really get more information on it.
Dr. Morris, while I have you, now you seem to feel that bamlanivimab was totally useless. Now, maybe you could comment on the Chen et al. Study in New England Journal of Medicine. Their numbers were, when used early, I think it decreased emergency room and hospitalization rate from 6.3% to 1.6%. And in those who were either obese or over 65 from 14 to 4.6%. Then there's the Blaze 2 trial. And talking to Dr. Silverman at Western, the head of infectious disease, about bamlanivimab, apparently there's been 6 different groups in Ontario trying to use it, infectious disease people. And according to Dr. Silverman, he says there are no trials suggesting that it doesn't work, whereas there are several suggesting early on in the disease that it is effective. So
Thank you. I'm not exactly sure what the question is, but I can comment on it. I will say that the data that we have from the trials so far are markedly limited. The number of endpoints are actually quite small. And there are two real challenges with bamlanivimab. One is identifying the people who will benefit, which is difficult early on. The number of people who would need to get administered the drug in order to prevent just a hospitalization orders around 100 people just to prevent one hospitalization. But more importantly, because it's a drug that needs to be administered intravenously, and the course of therapy is really 2 hours, 1 hour for it to be administered and then another hour of observation. And we would have to do that for the people who are most infectious. So it's early on in their course and they would be most infectious. On top of that, in order to identify them, first you need to get a positive test. And so what would normally happen in most centers around the country is someone would be tested, then they would get their information 1, 2, or 3 days later, and then they'd have to be brought back, where a lot of that early benefit would actually be lost. So for all of these reasons, the implementation challenges as well as the lack of information, it makes it a drug that at the moment, as far as we know, doesn't hold tremendous promise. I will also point out one other thing, which is what's been observed in the BLAZE trials is that when bamlanivimab is used as monotherapy, so it's used alone, we see these escape mutants, which are variants that are resistant to some degree to the immune system. They escape. And so what we'd rather have is, and what the evidence suggests is combination therapy. We don't have a second drug, and obviously that adds to more complexity and cost.
Merci, doctor. Thank you, doctor. Nous allons maintenant.
We'll now turn to Mr. Thériault. Please go ahead, Mr. Thériault. 6 minutes. Yes, thank you very much, Mr. Chairman, and thanks to all the witnesses for their testimony today. It's crucial. Dr. Nickerson, I remember a brilliant speech that was made at the very onset of the pandemic, and I was impressed. I said to myself, here we go. Here's some interesting and relevant take on this. We're facing a global pandemic in the face of which experts have been outsmarted. Perhaps they weren't experts after all, because we thought that it would just remain contained in continental China. But we know that the virus didn't stay in continental China, and we know that we are confronted with a global problem. The solution? Well, it was vaccination protectionism, wasn't it? So how do you explain that, if you would, in the briefest of terms? And now that we see the vaccines flowing in, as my colleague Paul Hoos said, will we need to go and take vaccinations from the COVAX bank anymore?
Thanks very much for the question. I mean, I think that the point that you're getting at is that, you know, this is a global public health emergency, and what happens in one country affects all of us everywhere. So, you know, disease control and public health interventions that are applied inequitably or only in one country are simply not going to be effective at ending the pandemic, because we live in an interconnected world where disease knows no borders. To the question of vaccines and vaccine access, I mean, I think that it's very clear that what we have seen over the past 3 months as vaccines have started to roll out is that the vast majority, almost exclusively all of the vaccine doses that have been administered in high-income countries. As I said, there are only this week shipments of COVID-19 vaccine doses arriving in countries through the COVAX mechanism. And a large reason for that is that the available vaccine supply has largely been monopolized by high-income countries up to this point. So we face a fundamental problem of of high need, high demand, and extremely limited supply up to this point. On the issue of COVAX specifically, I want to be very clear that I actually think that Canada participating in COVAX as a purchasing country was appropriate at the outset. This was a mechanism that was intended to be a global procurement mechanism that would be guided by principles of equitable access to prioritize high-risk healthcare workers and other vulnerable people as a global priority. That was the deal. We vaccinate the people who are at highest risk in every country, everywhere, as a matter of urgency. And having purchasing countries participate in that to demonstrate that we were not just invested in this as a charitable function, but actually as a mechanism for changing the way that we procure and distribute vaccines, I think was appropriate. Now, to then also sign bilateral agreements for a large number of vaccine doses, which is the situation that Canada and other high-income countries are in today. I think to then go and draw on the COVAX mechanism at the same time as effectively monopolizing the global supply, I think that's not appropriate. But the solution here is that Canada should sit this first round out, because we need those COVAX doses to be going to countries that are entirely dependent on COVAX as their procurement mechanism, and who don't have the same kind of bilateral deals that Canada and other countries have.
Dr. Maurice, on va profiter du...
Dr. Morris, we have a panel here. So do you agree with Dr. Nickerson on this point?
I do, as a matter of fact.
Vous préconisez,
Dr. Morris, would you recommend, and I'd like to ask about remdesivir and the bumsy bibi bub, I've butchered that, but do you favour a tightening up of public health directives? What needs to be done in addition to what's already being done in order to contain COVID entirely? Are we on the right track, or are there things that we should be doing to help more by tightening up public health measures, and in what contexts exactly, please?
That's probably a 10-hour conversation, but I will try and narrow it as much as possible. I'm going to focus first on the public health measures that you have suggested. I think one of the things that we haven't done well in Canada in particular is taken on a national strategy or a pan-Canadian strategy. So instead, what we have is a mixture of strategies. The territories and the Atlantic provinces have taken a maximum suppression approach, which has unquestionably saved lives and doesn't appear to have substantially harmed their economy, whereas all of the other provinces have taken a pure mitigation approach. How you get there, I don't think there's any question of how you get to a maximum suppression strategy. The Atlantic provinces and the territories have demonstrated how to do that, and that includes tight controls on movement of people and travel, aggressive testing, contact tracing, isolating, and supporting those who need help in all those aspects, and a very data-driven approach that targets zero, even though you may not actually achieve zero. So I think that as a national strategy, if there were to be a national strategy, then all the things that would be included in those would be necessary. It looks like I don't have time to answer the drugs.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
To Mr. Davies. Mr. Davies, please go ahead. 6 minutes.
Thank you, Mr. Chair. Thank you to the witnesses for being here. Mr. Scott Douglas, last week, you appeared at the Industry Committee and you said the following: we looked at all the other task forces, including warp speed. What Canada is doing is largely equivalent to what everybody else is doing. There's a great deal of confidential business information, and that necessitates that meetings be held in confidence, the same as almost every other task force. Of course, the difference is that the U.S. Vaccines and Related Biological Products Advisory Committee does publish its agenda, its conclusions, and its entire meetings are webcast on YouTube for anyone to see. Why can the US be transparent and Canada can't?
Mr. Chair, I think that's an excellent question. The transparency, to the degree possible, is obviously the goal we should all be seeking to achieve. Though the work of the vaccine task force is not equivalent to the group that you've identified in the United States. That is more equivalent to the regulator in Canada, Health Canada. The work of Warp Speed, where they were dealing with sensitive confidential business information, making decisions at an early stage that were then subsequently authorized later through the FDA, et cetera, was done in private and confidence because of the confidential business information that we've talked about. And that same practice was generally followed by all of the leading vaccine task forces.
Okay.
The work of the regulator is a little different.
Got it. Can I move to the Federal Vaccine Task Force has a declaration of interest protocol, which requires all members to give a full disclosure of activities and interests that could place them in a potential conflict of interest to the federal government. Is there a reason why those members' disclosures have not been made public?
It is extremely important that decision making around advice given by the task force is made fully aware of potential conflicts of interest and interest generally. The ministers of ISED and health and procurement are made fully aware of all of the interests relevant to advice given in that context. In any case where the government has acted on that advice and has announced the funding of projects are commended, the interests of task force members relevant to those decisions have also been made fully public.
Okay. To you, Dr. Langley, I know that drawing on the advice of the Vaccine Task Force last September, the federal government pre-ordered 72 million doses of the vaccine candidate developed jointly by GlaxoSmithKline and Sanofi. It's Canada's second largest vaccine supply agreement. Dr. Langley, you, I think, currently hold the $700,000 CIHR GlaxoSmithKline Chair in Pediatric Vaccinology at Dalhousie University. And I believe you've worked with Sanofi on research and as a consultant in the past. By standard conflict measures, was it appropriate for you not to recuse yourself from discussions relating to the GSK Sanofi vaccine candidate?
Thank you for the question. So just to clarify the research chair that I hold, this was an endowment that was created, started to be developed between 2000 and ultimately was posted as an application on the Canadian Institutes of Health Research website. The endowment funds came from the Canadian Institutes of Health Research, the Dalhousie Medical Research Foundation, the Department of Pediatrics, several other smaller charitable agencies, as well as GlaxoSmithKline. With an endowed chair, the money goes to the holder of the chair, which is Dalhousie University, and then the funds that arise from the endowment are used to support research.
With respect, Dr. Langley, I don't need to understand how it works. I do understand. I'm asking if you think it was appropriate not to recuse yourself, given the clear link between GlaxoSmithKline financially and the position that you hold.
Thank you. So I think it's important to understand if there is a conflict of interests. In this case, I have no material benefit to gain from an endowment that's held at Dalhousie University. Okay. And I'll turn to Roger Scott Douglas to explain the process for management of conflict of interest.
Yeah, that's fine. I'll control the questioning here if I can. Dr. Nickerson, South Africa and India have put forward a proposal at the WTO to exempt member countries from enforcing patents, trade secrets, and pharmaceutical monopolies under the organization's agreement on trade-related intellectual property rights known as TRIPS. And of course, the aim of that is to ensure that vaccines and other technologies needed to control COVID-19 are available universally across the globe. What position is the government of Canada taking on that position? And in your view, what should Canada's position be?
Thank you for the question. So I believe Canada's official position on this is that we have yet to have an official position on this, which is to say that Canada is sort of officially saying that they're not rejecting the proposal. To cut right to the chase, countries should be supporting this proposal. Patents and other intellectual property rights have historically been barriers to access to medicines, particularly for people in low and middle income countries. The TRIPS waiver proposal that's in front of the WTO at the moment is a needed and important mechanism for removing intellectual property rights as being a barrier to accessing COVID-19 technologies, and Canada should support it.
Thank you, Mr. Davies.
Thank you.
So we're going to try and squeeze in a quick round, 1 minute per party, and if questioners could try to keep their questions to 30 seconds or less to allow 30 seconds or so for the answer, that would be great. So we'll go now to Monsieur D'Entremont. Monsieur D'Entremont, please go ahead, 1 minute.
Well, a couple of quick points, and this is to Dr. Langley, and maybe to Mr. Scott, and getting the minutes of the task force. There are other ways for political parties to get information from different committees, and I mean they might end up being a little blacked out, and making it try to understand what happened at the task force and how decisions were made. I'm just wondering if knowing that, could you not provide us a copy of the minutes of the task force meetings?
I think, thank you very much, Mr. Chair. Thank you very much for the question. I think that active efforts are being looked at now, how we can recognize as much transparency as possible while protecting the confidential business information that legal agreements have been entered into to protect. And so that's under active consideration.
All right, can we make sure that they're provided to this committee as soon as they're available? I don't want to do a motion. I'd like to do a motion just to make sure they come here, but I'm going to use your best judgment to actually have that provided to us.
Yeah, every effort, Mr. Chair, will be made to get information to the committee in a timely fashion, recognizing that we'll need to redact the confidential information, of course.
Thank you, Mr. D'Entremont. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 1 minute.
Thank you, Mr. Chair. We've heard a lot about the need for pan-Canadian initiatives, firstly for data sharing, and now Dr. Morris has suggested that we have a national committee of experts on infectious diseases. So how would Dr. Morris propose that we implement this? And you had mentioned earlier there was an Atlantic example, and perhaps there's some lessons that we could have learned from that. How should we go about implementing this pan-Canada presence?
I think there's a few options available. Some of those would require legislation. The Public Health Agency of Canada was born out of the SARS Commission and a recognition that we did need a strong federal response to infectious diseases and pandemics. And over time, FAC has seen its budget and its overall strength diminished by effective reductions in budgets, et cetera. So I think that's one aspect of it. The second thing I would say is that NACI has proved itself to be an efficient structure and organization for immunization practices, and has effectively advised provinces who have then contextualized the advice from NACI. I don't see a reason why a similar approach for whether it's therapy of infectious diseases or overall strategies to tackle infectious diseases can't be structured in a similar manner.
Thank you, Mr. Van Bynen. Nous allons maintenant Monsieur Thériault. Monsieur Thériault, 1 minute.
Mr. Thériault, the floor is yours. 1 minute, please. Yes, Dr. Morris. As far as immunity is concerned, Dr. Bernstein said at the last meeting that mixing vaccines, first dose, for example, Pfizer, BioNTech, second dose, AstraZeneca, was something that it could in fact strengthen herd immunity. What do you think of that remark?
Although I have a personal view on it, I actually think that Dr. Langley's more expert to answer that than myself.
Thank you, Dr. Morris, and thank you, Mr. Chair. These are questions that are very important to answer. I don't think we have the answer to those right now, and they should be studied. it is very important to know the effect of the second dose on maturing the immune response in a way that is safe and effective. And that's overall been the concern about changing whether there is or when you give a second dose. So these are important public health questions that the member has raised, and I think we should address them.
Merci, Monsieur Theriault. We go now to Mr. Davies. Mr. Davies, go ahead, 1 minute.
Thank you. Dr. Langley, you and your colleague Scott Halpern are registered as principal investigators on the phase 3 trial of the COVID-19 vaccine developed by CanSino Biologics. We know that's the partnership with the NRC that collapsed this summer. Did you recuse yourself from the vaccine task force's deliberations on the CanSino vaccine?
I would have declared my interest, and I don't remember, Roger.
Yes, the CanSino.
I'm just asking if she recused herself, that's all.
The very first time CanSino was discussed, it was reviewed in the list of the international candidates, and then Dr. Langley indicated that she had.
I'm sorry, I have limited time. I'm asking about recusing. The reason I want to get to that is, excuse me, sir, that you're not answering my question.
She indicated that she would recuse herself from any discussion.
The reason I ask is Dr. Kobinger said that he voiced very strong concerns despite the fact that this was officially the first recommendation of the committee, but they had never really discussed the CanSino recommendations. We didn't know how it was made as a first recommendation. Can you explain why a recommendation on CanSino was the vaccine task force's first priority?
It wasn't the first priority, and Dr. Kobinger only came to very few, 2.5 meetings. Most of the discussion occurred after he stopped appearing at the task force.
Thank you, Mr. Davies.
Thank you.
Point of order, Mr. Speaker, or Mr. Chair. Before we get on to the next panel, I'd like to ask a question.
On a point of order, Mr. Dantemot, please.
Thank you. Just wondering, from the meeting last week, there was a number of undertakings from PHAC to provide us with some information. Have we received any information from PHAC and the questions that we had asked that they said they would follow up on?
We've received a number of submissions from various people. I don't know exactly if they've been resolved. It's a question we can ask for the clerk. So the clerk has shaken his head.
No, I haven't received anything.
So not at this time.
Okay, thank you, Mr. Chair.
All right, thank you, Mr. Dantemot. So I'd like to thank all the witnesses for appearing today and giving us your time and your expertise and your great answers. So thank you very much. And we will now suspend and bring in the next panel. So thank you all.
Thanks.
So welcome everyone, welcome back. We are resuming meeting number 21 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the second wave of the COVID-19 pandemic. I would like to welcome the witnesses. We have, as an individual, we have Dr. Cécile Tremblay, full professor. From the Canadian Association of Emergency Physicians, we have Dr. Alan Drummond, co-chair, Public Affairs Committee, and Dr. Atul Kapoor, co-chair, Public Affairs Committee. We have, from the Public Health Agency of Canada, we have Mr. Ian Stewart, President, who will be making a presentation, and we have Major General Danny Fortin, Vice President, Vaccine Rollout Task Force, Logistics and Operations, who will also be making a presentation. So we will start now with the witness statements. I would advise everyone, remind everyone that I will be using a yellow card to indicate when there's about a minute left, if I don't forget, and a red card when your time is up. So when you see the red card, please try to wrap up. Okay, so we will start with Dr. Tremblay. Allez-y, s'il vous plaît.
Please go ahead, Dr. Tremblay, 6 minutes.
Tremblay. I'm an infectious disease specialist and a medical microbiologist at the Centre Hospitalier de l'Université de Montréal. I hold the Pfizer University of Montreal Chair on HIV Translational Research. I've been working for decades on correlates of protection that could be used for vaccine development in HIV. This goal has long eluded us for HIV, so we've been thrilled to see the rapid development of highly effective vaccines against COVID-19 in such a short period of time. But several challenges persist. Vaccines do not stop pandemics, vaccination does. 3 factors will determine if herd immunity can be achieved in Canada through vaccination. First, the availability of vaccine, the supply. Canadian researchers have been working hard on developing new vaccine, work that has been supported by the Canadian government through CIHR and other funding mechanisms. However, the time frame for the development of a new vaccine amenable to clinical trial in Canada is unlikely to yield products available for us in 2021. I'm talking about the homegrown vaccines in Canada. These research efforts should continue, though, to be supported as they may become useful if the pandemic persists or if variants render our present vaccines obsolete. At the moment, we have to rely on existing vaccines, which are in short supply, not only in Canada, but throughout the world. Because of our deficient Canadian vaccine manufacturing infrastructure, we have had to rely on importation of vaccines produced elsewhere, which with all the delays that it creates. Lessons learned from previous pandemics had identified the need to produce vaccines in Canada as a priority as part of a pandemic preparedness plan. Unfortunately, little was done, and although we have had some companies manufacturing vaccine in Canada, such as Sanofi Pasteur in Toronto and GSK in Quebec City, their capacity for large-scale production is limited. The recent initiative of the federal government to develop a vaccine manufacturing facility in the Royalmont district in Montreal is commendable. Other facilities associated with research centers are also being created, such as the one in Saskatoon. However, if we want to develop a sustainable infrastructure for vaccine development and production in Canada, we must also support the presence of a variety of pharmaceutical industries, from homegrown biotech, such as Medicago in Quebec City, to big pharma, to maintain the scientific expertise in Canada and avoid the brain drain of our young researchers to the US. This means reversing an unfortunate trend over the last decade. In 2007, AstraZeneca and Bristol Myers Squibb shut down their manufacturing operations. In 2010, Johnson & Johnson and Merck's research center in Montreal closed. Several other companies, such as Pfizer, Abbott, and others, research facility that were based in Quebec were also relocated abroad. So if we want to make sure that we have sufficient vaccine supplies for the next pandemic, we need to have an infrastructure that includes both a government-administered manufacturing capacity and a strong pharmaceutical industry presence. The second factor in achieving herd immunity is the ability to establish mass vaccination programs accessible to the entire population. From what we can observe in Quebec, this seems to be quite well organized. But the third factor is vaccine hesitancy. This is not specific for COVID-19. Misinformation on vaccines has been circulating for decades and has accelerated in recent years on social media. COVID-19 has intensified conspiracy theories, which have instilled fear in a significant proportion of the population. To achieve herd immunity, it is believed that 75 to 85% of the population needs to be vaccinated. At the moment, a good percentage of the population is eagerly awaiting their vaccine. These are the low-hanging fruits. The challenge will be to reach out to those who are hesitant, not necessarily against vaccination, but who need to have their questions answered. And so far, it is not clear to me what is the communication plan. People who are hesitant about getting vaccines are spread throughout society, across all ages and all socioeconomic strata. Specific communication strategies must be developed to address their various concerns. Finally, phase 3 vaccine clinical trials usually exclude certain populations, such as immune-compromised people, HIV positive, transplant patients, cancer patients receiving immunosuppressive therapies, pregnant or breastfeeding women. However, we know that these populations could benefit from vaccine, but we are always in a gray zone because data has not been collected. It could be that because of their immunosuppression, their antibody response may not be as high or effective. We might need to use a different strategy, such as adding booster doses. Usually, researchers initiate research projects, like I do, to test vaccines in these populations. They apply for a grant, and if they are lucky, they get funded. There is always a problem in accessing the product that we want to test to conduct these clinical trials. Phase 4. This is particularly true when the supply is limited, such as is the case right now. So testing new vaccines in these various populations should not be left to individual initiatives. It should be mandated by the government, and resources as well as vaccines should be available automatically to conduct these phase 4 trials once the vaccines are approved. In the midst of this devastating pandemic, vaccines are the shining light on the horizon. Let us learn from previous pandemics and build a durable infrastructure encompassing research and development, manufacturing, distribution, so that we're ready for next time. That's it.
Merci, Doctor. We go now to the Canadian Association of Emergency Physicians. Dr. Drummond or Dr. Kapoor, please go ahead, 6 minutes.
I believe that's Dr. Kapoor, actually.
Okay, go ahead, Doctor.
I apologize. I thought Dr. Drummond was going to lead us off. Thank you for the opportunity to appear. We plan to utilize our time to focus on the immediate situation of vaccination and the vital need to engage with frontline workers and their associations. There are other points that we will also be mentioning later on. Our first priority has to be to repeat our call for increased transparency around the prioritization and administration of the COVID-19 vaccines and the plans for the vaccinations going forward. Unfortunately, there still remains confusion, lack of transparency, and mixed messaging around prioritization. We urge there to be central federal coordination of efforts with clear and consistent transparent messaging. And why are we calling for this? Because we see the stark example of this problem in the fact that there's still people working in Canadian emergency departments who have not been vaccinated or completely vaccinated. And of particular concern for us are those working in smaller, isolated, and rural communities. We are highlighting healthcare workers because of the precarious state of the healthcare system and its dependence on workers who are already overstretched. Plainly said, if our healthcare workers are incapacitated due to COVID-19, the system won't be able to take care of the population at large. And as I said, but needs reinforcing, most troubling is the fact that vaccination has been delayed for emergency personnel in rural and isolated communities. And the risk there is that because they don't have as many people and as many backup personnel, the smaller population of providers means that there are not others who can step up and fill in for colleagues who fall ill. And the risk of system collapse in rural communities is much higher. That also has caused frustration for healthcare personnel and added to the burden of working in a system that was already overloaded even prior to the pandemic. We as healthcare workers have been repeatedly thanked. We've been hailed as heroes, but the reality is that we are workers, no less than any others, who deserve a safe work environment. Instead, all too often, the assumption has been that we will simply accept increased risks without consistent evidence-based assessment and mitigation of those risks. In fact, we even saw last week one of the provincial government failed to recognize that emergency department nurses are a higher risk group and treats COVID-19 patients often before they've been identified as cases. Our members and our colleagues on the front lines have continued to step up and care for the sickest patients in our communities. Transparency, communication, and adherence to an ethical framework in vaccine prioritization and administration are the minimum that they should receive in return. We saw many missteps up until now, and we are looking forward to the ramp up, but we want assurance that those missteps won't be enlarged and expanded as we ramp up. We also want to talk about the conditions that hindered the response to the COVID-19 pandemic and that need to be addressed now in order to prevent the third wave that's even worse than the second, and to support the healthcare system's ability to respond and to resolve vulnerabilities prior to the next healthcare crisis. Think about the idea of a system that's resilient and able to respond. It needs surge capacity, which is eliminated when there's pre-existing crowding. It needs adequate staff, which requires HHR planning, adequate supplies, which requires stockpiles and domestic production capacity, and a strategy to prevent shortages of medications and supplies. It needs an appropriate working environment, which requires hospital design and requires adequate leadership and decision making, such as an incident management system and clear communications. We went at the beginning, emphasized the point of keeping the system resilient, which requires vaccinating staff so that the capacity is there. I'm going to touch on a couple of these points specifically. When we talk about surge capacity, we saw that hospitals completely shut down in wave one in order to create capacity to handle anticipated COVID-19 patients. We need hospitals most appropriately function at 85% capacity. Even before COVID, most hospitals in this country were operating at or above 100%. That is not suitable, it's not appropriate. It wasn't then, and it isn't now, and it won't be in the future. We cannot go back to the old normal. And that has added to the strain on emergency department workers. We have been and are continuing to see emergency department staff leave the emergency department to work elsewhere, leave the profession, and unfortunately, in some cases, we have seen at least one colleague who has been lost to suicide in the last year. I see that my time is coming to an end. We have submitted a written brief with more details, but we will be happy to answer questions from the committee. Thank you.
Thank you. We go now to Mr. Ian Stewart, President, Public Health Agency of Canada. Please go ahead, 6 minutes.
Okay, thank you, Mr. Chair, and members of the Standing Committee on Health for inviting Major General Fortin and myself to return today to inform and discuss with you your work on vaccines. The Government of Canada has taken a whole of government approach to much of the work we've been undertaking in response to the pandemic, as you know. And we've been relying on accumulating scientific data and emerging evidence and pulling on expert guidance to inform our decisions, our strategies, and our recommendations. We're also participating in international communities of practice in order to benefit from the experiences and developments in other countries. As you know, we've begun our phased approach to vaccinating Canadians, and I'm pleased to say we're on track to complete phase one by the end of March. As expected, we're ready to move on for phase 2 in April, and Major General Fortin will be speaking more about the upcoming big lift we require to get ready for the influx of additional vaccine doses. Last fall, the Vaccine Rollout Task Force was established inside the Public Health Agency of Canada in order to provide public health and strategic policy advice to decision makers, but also to oversee the management of the delivery of the vaccine portfolio. That included logistical planning and tracking of data on a secure platform as vaccines are deployed and distributed across Canada, and to provide leadership and support to the various fora of the immunization experts like the National Advisory Committee on Immunization or the Special Advisory Committee, as well as managing vaccine surveillance programs for issues such as vaccine safety, effectiveness of the vaccines, and the coverage of the vaccines as we deliver them. In order to fulfill its mandate, this internal task force was working closely with provinces, territories, and Indigenous leaders and communities across the country to support a consistent approach to COVID-19 immunization. The task force expert advice and leadership has been invaluable over the past quarter and will be invaluable going forward as we move into the second phase. Throughout the pandemic, public health practices and efforts of all Canadians have proven to be effective in containing the spread of the virus. Our efforts have brought us this far, but we have to continue wearing our masks and washing our hands and physical distancing as we move forward until the immunization campaign is well advanced. We also need to rely on effective border measures to mitigate the further introduction and spread of the virus and the virus's variants into Canada. And that's why, as of this month, travelers arriving in Canada have to produce at the border a molecular test done before our arrival in Canada, and then they are tested again at the day of arrival and day 10 of their quarantine. They have to continue to present quarantine plans that are appropriate and contact information for us following up with them. COVID-19 virus variants of concern have emerged in countries around the world, and there's evidence these variants are more easily transmitted, and there is the risk that they cause more severe illness. So these variants require our attention, and we need to track them. We need to learn more about them, and we need to use science to guide us. In this regard, the government recently allocated $53 million in funding for an integrated variants of concern strategy, which builds on sequencing, research, and surveillance capacity for detecting the variants and informing public health measures. This vital work has provided decision makers with the latest science on controlling for variants of concern, and we'll continue to respond accordingly and explore options for variants such as vaccine boosters to control against their spread. Canada successfully secured a diverse portfolio of vaccines, as you well know, to vaccinate everyone in Canada who wants to be vaccinated by the end of September. And to this end, Canada has negotiated advanced purchase agreements with 7 pharmaceutical companies. This includes a diversity of vaccine technologies, 2 mRNA vaccines, Pfizer and Moderna. And as of this morning, as you'll know from the announcements, AstraZeneca has been authorized by Health Canada as well. Several other vaccines are currently under review using the rolling review process Health Canada has developed. AstraZeneca will help with the immunization campaign starting relatively soon. I believe today as well, announcement was made about initial doses, early doses, which will help us begin to take on board these new viral vector vaccines as part of our immunization campaign. Last fall, NACI, the National Advisory Committee on Immunization, identified priority populations that would be vaccinated first. In anticipation of increased supply, they will be updating their advice on who should be the priority populations. We will be continue to be guided by their evidence and their advice in the work that we do. Thank you very much, Mr. Chair.
Thank you, Mr. Stewart. We go now to Major General Danny Fortin, Vice President, Vaccine Rollout Task Force, Logistics and Operations. Please go ahead, General, 6 minutes.
Thank you very much, Mr. Chair and members of the Standing Committee. I'm pleased to provide the committee an update on the progress we've made so far and plans moving forward to provide all Canadians vaccines by the fall. So far, the National Operations Center here at the agency has distributed nearly 2.5 million doses of both approved vaccines, Pfizer, BioNTech, and Moderna, with approximately 3.5 million coming next month to round out our 6 million announced commitment of both the manufacturers. Since last December, we've been working on a plan that will allow us to deliver authorized vaccines safely and efficiently and as quickly as possible to provinces and territories. We deliberately implemented a phased approach so we could establish our capacity to distribute vaccines and support the provinces and territories to administer vaccines. So we completed a series of tabletop exercises and various discussions and rehearsals with provinces and territories to ensure that all critical capability gaps were filled, that risks were identified and mitigated, that the plan was resilient, and contingencies were in place to secure the vaccine supply chain. And that continues today. As part of our soft launch approach last December, we started with early deliveries of authorized vaccines to 14 designated points of use on the 14th of December across Canada. As we move forward, we expanded the number of distribution sites. Last week alone, 107 vaccination sites were used for Pfizer and 83 for Moderna. Also, I personally conducted multiple bilateral meetings with counterparts from provincial and territorial vaccine rollout leads, as well as federal stakeholders, to ensure that we're all on the same page and we continue to have those moving forward. Monsieur le Président, au cours des 2 derniers mois,
Mr. Chairman, over the last 2 months, Canada was significantly affected by COVID-19 vaccine shortages and delays as Pfizer, BioNTech and Moderna reduced production rates at their respective European facilities. This created a temporary delay for deliveries to Canada, but the improvements in manufacturing are now allowing for greater productivity. From the beginning, we have been open about fluctuations in supply and contingency plans with our partners and stakeholders. I want to emphasize that we are expecting 444,000 doses each week in March from Pfizer BioNTech. That's each week in March. That is more than 2 million doses in 5 weeks. We are also expecting 1.3 million doses from Moderna before the end of March, so we're on track. Starting in April, we expect a steep increase in vaccine availability from currently authorized COVID-19 vaccine manufacturers. And with AstraZeneca's announcement today, well, those quantities will be added on top of that. We are expecting around 23 million doses to arrive between April and June. This includes the accelerated delivery of an additional 2.8 million doses of Pfizer BioNTech from the summer through to the fall, or rather spring. The National Operations Centre continues to lead the planning effort to ensure that the provinces and territories will have the capacity they need to keep pace with increasing shipments of the authorised COVID-19 vaccines. Additionally, the National Operations Centre continues to ship a cold chain enabling equipment that will further bolster the capacity of the provinces and territories, be it fridges, chilling devices, such that the products can be kept at the appropriate temperature. Our collective efforts over the past weeks and months, the early rehearsals of our distribution and logistics systems, and the launch of the Pfizer, BioNTech and Moderna vaccines have all served to set the conditions for a rapid scale-up as vaccines became more readily available in the months ahead. So the same approach will be taken over the upcoming weeks in close cooperation with the provinces and territories as far as these additional vaccines are concerned. Coordination and cooperation with our federal, provincial and territorial partners is key to this operation's success. We regularly communicate updates or changes in the vaccine delivery plan so that the provinces and territories are able to plan immunisations that are in line with vaccine availability.
our provincial and territorial counterparts continues to be done proactively and transparently. This is a cooperative effort that touches on everything from vaccine availability to enabling equipment to considerations by healthcare practitioners. So we're in close coordination and will continue to do so over the next several months. Every step of the way, ensure that vaccines continue to be delivered efficiently and safely across the region of Canada. We've been working collaboratively with all stakeholders, and we'll certainly endeavor to do so moving forward. With that, subject to your questions, this concludes my introductory remarks. Thank you, Mr. Chair.
Merci, monsieur. On commence.
Thank you, sir. Let's get started with our Q&A period, and we'll start with Mr. Paul Oos. Mr. Paul Oos, please proceed. You have 6 minutes, sir. Thank you very much, Mr. Chair. Hello, everyone. Thanks for being with us. I'd like to start with you, Major General, and I'm pleased to see you again. Earlier, you spoke in your opening remarks about the coordination with the provinces, and I want to be clear with everyone right off the bat. You were assigned to the logistics and distribution in Canada, but you're not the one who signed the contracts upstream. You didn't negotiate. You arrived and you're in charge of the rollout. So we understand that there were a very limited supply at the outset, but all of a sudden we're going to have a lot of vaccine at the same time arriving. Now, the provinces, have they said that they can absorb that capacity? And if there are problems, which are the problematic provinces and territories? Response. Thank you very much, Mr. Chair. I think that there's going to be ongoing efforts over the upcoming weeks. But over recent weeks, we, along with the provinces and territories, looked closely at what their needs and capacity was. And I'm very pleased to say today that there are provinces that are very advanced in the establishment of mega vaccination sites, mobile clinics, drive-thrus, and across the board, there is a plan to use pharmacies and pharmacists' distribution networks for the rollout. There are plans that are being fine-tuned and finalised to employ retired folks and folks that aren't traditional conventional vaccinators who will pitch into this effort. So across the board, we have a game plan in place. This is a provincial and territorial area of jurisdiction, so the buck stops with them when it comes to the immunisation program. It's their purview. And so there are being lessons learned that are being shared. Question, well, as a rule of thumb, you said that there are 23 million doses in between April and June. So are you able to plan in light of that? And will each and every province know how many doses will be arriving? And are there any logistics issues? Because in Quebec, you will be receiving 5 million doses, but perhaps they don't have the capacity in Quebec to use those vaccines. Are there misgivings and concerns on the part of the provinces? Response. Well, if there's no transparency and visibility about quantities and shipments, it's difficult for the provinces to, of course, manage the rollout. They have said that the provinces have said that the demand will be there, that they do have capacity, and the best way to help them for the time being is to provide as great a level of predictability in terms of quantity and shipments. That's what we're hearing from the provinces for the time being. Thank you very much. Well, in the opposition, we've done our math. It's perhaps not scientific calculations, but it'll take 3 million Canadians vaccinated on a daily basis in order to reach the target that the PM announced for September. Is it feasible? Is it possible? Mr. Chairman, these are forecasts that we are using too, and we're sharing them with the provinces. I do get the keen sense that we're on the right track in that regard. What can we do to help the provinces on an ongoing basis? Well, we can identify risks, any points of friction, any stumbling blocks, so that we can rely on our logistics backup and put in place the fridges at the right locations, prioritise distribution so that we can ramp up the rollout in a significant material manner. The provinces have said they're able to do this over time. That's what we've told the provinces. We're going to continue to work alongside the provinces so that we don't end up in a pickle when it comes to administering the VOSAs down the track. Final question. As far as planning is concerned, the 6 million doses was slated. It took time for them to arrive, and all of a sudden they're arriving right now. The agreement was signed quite late, but as of the 1st of April, there will be 26 million doses for the second quarter. But what about summer? June, July, August? Do we have figures that the companies have provided you with at this stage of the game? Response. Well, in fact, Mr. Chairman, we have 23 million Pfizer and Moderna doses coming in the second quarter. Third semester, we have another several million. So that's a total of over 80 million. And now we have AstraZeneca that's now part of our portfolio. And the exact quantities in the second and third quarters are to be confirmed. But here we have 25 million additional doses that have been added to our portfolio as of, in all likelihood, the 1st of March, based on the announcement from the Sino Institute. So that's the information we've shared with the provinces. Obviously, we now need to turn to the provinces and say, here are the quantities that we're about of doses that we're going to get. This is what the rollout process will look like so that we don't end up with doses that don't have the prerequisite capacity to be administered. So there you have it. That's the plan for the first delivery of AstraZeneca vaccine. Question. So are you confident that by late September all Canadians will be vaccinated? Mr. Chairman, that is what the figures are telling us, that we have sufficient quantity coming through the pipeline to vaccinate all Canadians by late September. Thank you very much. No more questions. Thank you, Mr. Chairman.
Merci. We go now to Ms. Sidhu. Ms. Sidhu, please go ahead. 6 minutes.
Thank you, all the witnesses, for joining us today when we received the news on the approval of the AstraZeneca vaccine by Health Canada. Mr. Chair, I want to begin my round of questioning with a few brief questions to our witnesses to set the record straight for Canadians watching. So my first question is to Mr. Stewart. Most of the GTA is presently under the stay-at-home order. Is it correct to say that the province of Ontario and not the federal government imposed it based on the consultation with regional and provincial public health experts?
Yes, it would be the province of Ontario that would be establishing what is the public health measures of that nature.
Thank you. And General Fortin, is that correct to say that the federal government distribute vaccines to provinces per capita and the provinces are responsible for local vaccine distribution, including through online booking portals?
Yes, Mr. Chair. While we were where we focused in the last few months or up until now on establishing the distribution networks, we're really focusing on supporting provinces administer and execute their immunization plan. And that's very much their responsibility.
Thank you. And General Fortin, how many vaccine doses have been distributed to the province of Ontario, and how many have been administered by the province, and how many are presently in the fridges?
Mr. Chair, I'll need 10 seconds to find my data.
Please go ahead.
So, Mr. Chair, it's I think I'll have to get back to you in a few seconds, if I may.
Thank you, General Fortin. Can I ask the other question? You can come back on that question. So, General Fortin, AstraZeneca vaccine were approved this morning, and this week Canada received the highest number of Moderna and Pfizer vaccine. Are you confident the province will be able to increase their delivery capacity to keep up the supply coming in? Or do you have any concern? How are you preparing for the influx of vaccines?
Mr. Chair, we're really focusing on helping provinces identify the risks, identify additional requirements that they may have to help them immunize at scale. The AstraZeneca and other vaccines, non-mRNA, have less stringent, less demanding cold chain requirements where they can be stored in pharmaceutical fridges that you would find in pharmacies. So that gives us more options, and it's much easier to handle and distribute in the provinces and territories. So it's good news for provinces and territories.
Thank you. Would you be able to comment on the work of vaccine remote northern and Indigenous communities in Canada?
Mr. Chair, we are in close coordination with Indigenous Services Canada. And of course, with the provincial and territorial authorities as well, their colleagues that distribute vaccines, and the input of the different jurisdictions is also factored in or discussed at the numerous tables. So there's plenty of opportunity to take into account their considerations. We work closely with, as I said, ISC in addressing the particular requirements of remote Indigenous locations. And I have personally been part in numerous discussions with Indigenous Services Canada colleagues, with National Indigenous Organizations leaders. So it's an all-aware network that continues to develop, and we continue to address the particular concerns and requirements of every Canadians through those tables.
Thank you. Next question is to Mrs. Stewart. You said the NACI is giving a recommendation to vaccine prioritization. However, we see there's a difference between the provinces. How can you explain that difference between the provinces? At the end of the day, the province has to decide that which demographic is they are vaccinated first. Can you explain that?
Yes, that's an excellent point. Mr. Chair, the National Advisory Committee on Immunization provides advice on priority populations, as is being mentioned. And that advice suggests who to target vaccines to in first priority. And that was shared with the provinces and territories in an ongoing collaborative dialogue. But as is being pointed out, at the end of the day, each province and each territory have to make choices about who are they going to immunize within their jurisdiction first, because they're delivering the health care in that community.
Thank you. Mr. Chair, still I would like to say General Fortin to submit the answer to my question about the numbers, which I asked before. And so do I have a time for next question?
No. Thank you, Mr. Du. General Fortin, if you have those numbers, you can give them now if you have them, and otherwise I'll ask you to submit them to the clerk in due course.
Mr. Chair, thank you. So for the province of Ontario, at the end of March, I'd have to do some math in public to do as of today, apologies, but 1.57 million Pfizer doses. And for Moderna, 703,000 up to now. In addition, there is a newly approved table that's in circulation. So forgive me, I'm trying to get my hands down on that. I'll submit this in writing to the committee, if I may.
Merci, monsieur.
We'll now turn to Mr. Thériault. Mr. Thériault, please proceed. 6 minutes. Thank you. Thank you very much, Mr. Chairman. I'll start with Dr. Tremblay, if I may. Welcome, and thanks again for being here with us today, Dr. Tremblay and the other witnesses. Now, with the arrival of variants, folks are concerned, and the Public Health Agency of Canada has said that if we loosen public health measures too quickly, there might be new cases to the tune of 20,000 per day, And in Quebec, there might be 2,000 additional cases a day, according to the organization's Quebec counterpart. So in your opinion, do we need to tighten or loosen public health measures? Some people believe that they need to be further tightened until we have a critical mass of vaccinated people. Thank you very much for the question, Mr. Theriault. Mr. Chairman, it is important to be concerned about the issue of variants because it might change the whole game, if you will. You'll see that there'll be a spike in hospitalizations and infections. And so we need to see what happens with these variants. And in that respect, I don't think it's time to loosen public health measures. In Quebec, there was some loosening up of public health measures during the school break. But we're all concerned about, after this school break week, a spike in cases. But to my mind, I don't think that we should continue to loosen public health guidelines. I think that we should limit gatherings until we have a critical mass of vaccinated people. Question: as far as the vaccine's effectiveness vis-a-vis the first strain of the virus, and bearing in mind the whole arrival of these new variants, of course we're glad that the vaccines are here and have arrived. But could collective immunity be in peril? Response: as far as variants are concerned, there's the B177 from England. There's also the South African variant. And both Moderna and Pfizer's vaccines seem to be up to the task. Even if in relation to the South African strain, it does seem to be a little bit of resistance to the antibodies generated by the vaccine, but it's not sufficient to win over against the vaccine. Now, as far as AstraZeneca and the South African strain is concerned, we know that in terms of deaths, in terms of serious cases of COVID, all the vaccines are effective. But that doesn't mean, for example, that other variants might emerge that might be 100% resistant to the current vaccines. And that is why we have to have the national and provincial capacity to be able to manufacture vaccines, be they booster vaccines or different vaccines, because we might need them for years to come. Question: some have talked about the possibility of mixing vaccines in order to heighten immunity. Do you have a point of view on that, i.e. first dose Pfizer, second dose AstraZeneca? Because we're talking about, different vaccines here. There's no clinical evidence that would suggest that this is viable. There's no studies that have been conducted. And, Major General Fortin has announced the distribution of vaccines, which will be adequate. So there'd be no good reason to mix vaccines. Question: given the arrival of these variants on the scene, and given the fact that there have been very few vaccines administered to date, in some communities, shouldn't we still be relying more on rapid tests? And in what context, without necessarily a broad-based tightening of public health measures? Response: that's a very interesting and important question. Yes, there are rapid tests, but sometimes they're not as sensitive as the conventional tests. But there are several types of rapid tests, so we can't conflate them. But there are rapid tests such as antigen tests that are not as sensitive, but if they're administered regularly, well, then we can at least rule out the most contagious, or put a finger on the most contagious cases. And at the end of the day, we'll end up being able to screen out all these cases. So yes, there should be strategies that are tailored to communities where there seem to be breakouts, and you can proceed randomly or systematically. Both would be advisable strategies. Question: we're starting to hear about the whole notion of a vaccine passport. Do you have a point of view on that as far as the pandemic management and infection management is concerned, especially given the variants on the scene. Response, I think we have to be really careful as far as these vaccine passports are concerned, because we don't know the length of immunity from the vaccines. Some people will get 1 dose, some 2 doses. Will the immunity last 6 months, 8 months, 9 months? And what would a vaccine passport mean? Would it allow people to travel abroad and then all of a sudden they don't have any more antibodies left and they try to re-enter Canada? So before this whole idea of vaccine passports becomes popular, I'd like more evidence as in terms of the effectiveness of the vaccines, which would demonstrate that the individuals concerned are fully vaccinated and so that viruses from abroad don't spread in Canada. So it's a tad premature in my opinion. Thank you very much. I don't think I have any more time, Mr. Chairman.
No,
Well, for once I managed to finish on time, says Mr. Thériault.
C'est bon. Mr. Davies, please go ahead. 6 minutes, please.
The Prime Minister has repeatedly and publicly said that all Canadians who want a vaccine will get one by September. Now, I noticed you today said by late September. Why the shift in dates?
Mr. Chair, there was no shift in date. If I said that, that's by mistake. By September, and with the numbers that we're seeing with the approval of AstraZeneca, you'll see even more vaccines arrive sooner. So that date might be revisited at a future point in time.
Okay, thank you. Now, the U.S. is currently administering 1.45 million doses per day on average, and they plan to ramp up to a capacity of 3 million per day by April.
Pardon me, Mr. Davies, your mic needs to be adjusted, I think.
Sorry. The U.S. is currently administering 1.45 million doses per day on average, and they plan to ramp up to a capacity of 3 million per day by April. In contrast, Canada has only administered a total of approximately 1.7 million doses to date. General Fortin, what is the maximum number of doses per day that Canada is currently capable of administering?
Well, Mr. Chair, thank you. I think this is a question that is best answered by integrating the inputs from the different provinces. But what provinces are telling us that they can scale up significantly. They see no major obstacles to scaling up with the projections that we issued them. And I think that the efforts over the last few weeks and a culminating point that is the rehearsal on March 9th. It's not an end date, but it's a good, important waypoint to come together and confirm that we have good line of sight on our plans and additional risks are identified. So we might be in a better position to answer that in the fullness of time.
So as of right now,
Mr. Davies,
yes.
The clerk advises me you need to unplug and plug in again. I'll stop your time.
How's that? Is that
Still
better,
not
Mr. Chair?
good. Try that again.
Is that better?
I think it's better.
Is that better, Mr. Chair? Yeah. Sorry,
I believe
better?
so.
Okay.
We'll carry on from here.
Thank you. Sorry, General Fortin, to clarify, are you saying that as of today, we don't have a national number on how many vaccines we can deliver on a national basis? We don't know that number right now?
No, Mr. Chair, what I'm saying is that it depends on the province's ability to scale up. The number 300,000 a day that was mentioned earlier makes perfect sense, and as part of the projections that we shared with provinces.
Okay,
and
thank you.
they intend to scale up different types of vaccination clinics to meet that goal.
Okay, U.S. President Biden has committed 10,000 federal troops and the National Guard to participate in vaccinating American citizens. Has the government asked you, or has the Canadian Armed Forces been asked to participate in vaccinations? And have you been asked about that?
Well, Mr. Chair, there are ongoing discussions with the Canadian Armed Forces and Department of National Defence in close coordination with Indigenous Services Canada. Plans exist to support provinces that require it for some of their remote and Indigenous communities. You're actually seeing that now in northern Manitoba as well as northern Ontario.
That's good news.
And it's occurred in Labrador, Newfoundland as well. So it will likely continue as required.
Thank you. Mr. Stewart, if I can turn to you, you were president of the NRC until September 2020. Now, the day before, on August 31, 2020, the Prime Minister issued a press release that said that Canada would begin producing 250,000 doses per month by November 2020 at the NRC's Royal Mount facility in Montreal, and up to 2 million doses per month by the end of 2020. On August 31, 2020, when the Prime Minister said that, was that your understanding, Mr. Stewart? Was the Prime Minister accurate?
I just want to jump in and say that Canada is delivering 637 doses this week, just to answer your previous question. That is our current throughput for how many doses we're able to deliver. With respect to your question about projections and announcements made at that time, I believe that was tied to a thing that subsequently was set aside that had been arisen from the work that you've previously been talking about around the CanSino project.
I'm just trying to find out on August 31 when the Prime Minister was telling Canadians that the NRC facility that you were head of was going to be producing 250,000 doses in November. On that date, was he telling the truth to Canadians as far as you were concerned?
The NRC facility that you're referring to is the Royal Mount facility in Montreal, and that is on track to produce 2 million doses a month. And,
but not by November, not by November 2020, Mr. Stewart. That's the question.
Well, actually, as I just said, that was related to a project that didn't go ahead.
And did you know on August 31, 2020 that the project was not going ahead?
I did not know on August 31st that that project was not going to go ahead, but I think that that's something you should be discussing with people who were running the NRC after I left.
Well, that's the problem is that you went till September 1st, so you don't know the answer. And when I put that very question to the NRC chief after September, he said to ask you. So it seems that there's a gap here. Mr. Stewart, when you were president of the NRC in the spring of 2020, when the federal government announced an investment of $44 million, it was specifically, quote, to ensure that the facility complies with good manufacturing practices related to the development, testing, and scale-up of promising vaccine candidates. My understanding is that the reason we've been given for not producing those doses in November promised by the Prime Minister was that the facility never achieved its good manufacturing practices. So if you were given $44 million in the spring to achieve good manufacturing practice status, why didn't that happen?
Go ahead with your response quickly, please.
Okay, there were actually a series of funding announcements, and the funding announcements were to take a clinical facility and have the clinical facility achieve GMP. Over the course of the summer, the project evolved, and it became creating a large-scale manufacturing facility, and that large-scale manufacturing facility is on track, and it will be GMP.
Thank you, Mr. Davies. So, committee, that wraps up our round of questions. I think because we started a little bit late, we'll try and squeeze in another lightning round. So let us propose 1 minute per party. And again, I encourage members to keep their questions short to allow time within that minute for a response. So we'll start, I believe, on my list is Ms. Wimpel-Garner, but I don't think she's here. So perhaps it will be Mr. D'Entremont again. Or someone from the Conservative may. Oh, there's Ms. Wimpel-Garner. So go ahead.
It's all right. Mr. D'Entremont is going to quarterback today.
Okay, no, we're all fighting out who goes first. I thought it was Larry anyway. This is to Mr. Stewart since it is PHAC. Last week we had a number of your vice presidents or vice chairs or whatever the positions are within your department, and they committed to get some information back on it, especially on the data that PHAC would have used to tell the government on how to use or why they would use the quarantine hotels. Do you have that information available today, or can you also commit to make sure we have this by March 5th?
Thank you for the question, Mr. Chair. I think if I understand from the discussion that occurred last week, the question was, what was the relationship between the Alberta pilots and the current structure being used at the border with respect to the 3-day PHAC hotels, as they're being called? First of all, I need to point out that the Public Health Agency is actually part of the Alberta pilots. We provided $23 million in funding to enable the Alberta pilots, and we're partners with Alberta on those pilots. From that work, which is involving ultimately 52,000 people, hopefully by the end of the life of the project, we're learning about what is the right sequencing and timing of tests. And that knowledge that we've gathered through joining that project is in fact what we use to design the approach we're using at the border now. So it's a continuation of learning from being part of that pilot. I'm sorry, did I miss something?
I'm out of time. So.
Oh, okay.
Ron's talking without, or the chair's talking without his mic on there.
Sorry. Thank you, Mr. Dunstable. We go now to Dr. Pawlowski. 1 minute, please.
Yeah, Dr. Drummond, Dr. Kapoor is a fellow longtime emerge doctor who's moved on. Let me say, and you have to answer this question in relation to your particular hospital, your particular ER. But was your emergency room, was your hospital prepared in the early months of the pandemic to be able to start looking after COVID patients, making all the changes you need in order to do so? And as you know, the hospital's under provincial jurisdiction. Healthcare is primarily provincial jurisdiction. Did you get any assistance by the hospitals in coordinating a response and knowing where to go?
So the short answer to that question is no. In the first wave, we were sort of governed by media appearances of what was happening in northern Italy and New York City. Thankfully, we had a few weeks time to prepare for this potential onslaught of the novel coronavirus. We felt, I think, very much left on to our own devices in terms of inadequate protective equipment, mixed messaging, which led to confusion amongst clinical staff, an insufficient number of negative pressure rooms that was mandated after the SARS pandemic, and I guess we didn't learn, and our concern for ventilator and ICU capacity. And so our association actually had to kind of fill in the clinical gaps left by the educational void. And thank God, I guess, that emergency physicians, emergency nurses, paramedics on a good day are a very innovative bunch and responded, I think, in an exceptional manner to the challenge that lay ahead.
Thank you, Dr. Pawlowski. We'll go now to Monsieur Thériault. Monsieur Thériault, allez-y.
Mr. Thériault, 1 minute. 1 minute, Dr. Tremblay. Managing the pandemic, public health, it's all about mass medicine, and the public needs to adhere to the public health messaging and not give up. Some favor a centralized wall-to-wall approach. Currently, we have a decentralized approach by many parties, tailored to the different needs of one province to the next, from coast to coast to coast. Which do you favor? Which method, response? The management of a public health crisis requires a voice in unison and a degree of centralization. That doesn't mean per se, however, that it shouldn't be customized to local needs, because you can't have a cookie cutter approach when one province might have 0 cases of a virus, whereas in another province there's a crisis afoot. So I think that we need a single centralized model which is well coordinated with consistent and coherent messaging, and then you can tailor it down to local needs. Thank you.
Merci, Monsieur Thériault. And now to Mr. Davies. Mr. Davies, go ahead, please. 1 minute.
Mr. Stewart, a recent study from a British university found that in light of the emergence of the B117 variant, that the only way to reach herd immunity for the UK would be to vaccinate almost everyone, including children, with the more effective Pfizer vaccine. They found that vaccinating the entire population with the AstraZeneca vaccine would only reduce the R0 value to over 1. And meanwhile, the Pfizer vaccine would require 82% of the population. to be vaccinated to control the spread of the new variant. Has the Public Health Agency of Canada conducted similar modeling for Canada?
First of all, I'm not aware of that study, so we'll look for that with great interest. So thank you for that. Secondly, we have 70 million doses of Pfizer and Moderna, which are sufficient for the needs of Canadians. And so it'll become a question of vaccine hesitancy at a certain point can we achieve the number of people we need to with those two products.
Do we need to access the COVAX fund if we have 70 million Pfizer and Moderna vaccines?
The decision about whether or not to access the COVAX fund is not in my remit, so I might not be the best person to speak to it, but our overall strategy has been to have multiple vaccine candidates in order to try and bring forward vaccines earlier so that we can complete the immunization program in a timely manner. And AstraZeneca, through whether COVAX or through our direct APA agreement, is in fact a way to get more doses earlier, which I think Canadians are very anxious to have.
Mr. Chair, if I might, the study was from the University of East Anglia, Mr. Stewart, if that helps.
It does. Thank you, sir.
Thank you.
Thank you, Mr. Davies. And thank you to all our witnesses today for your time and sharing it with us today, as well as your expertise and knowledge. And thank you to all the members for a great meeting. And I look forward to seeing you all next week. And with that, we are adjourned.
Thank you.